thanks a lot for the opportunity to have a chat again today. Just wanted to just up front just say increasingly, I'm talking about anxiety, depression, and suicide, and it's kind of, you never know who's in the room, and you never know what experiences people have had. So I just want to put it out there that the things that I say today, they come from a research base, and so they might not represent all your experiences, but at the same time, it's really important that if I happen to trigger anything in you, or there's some distress caused, by all means let us know. I'm more than happy to chat through some of those things with you should that occur. As I say, it's very hard to know exactly people's experiences, so we get used to talking about these issues, but sometimes they can create a few challenges along the way. I've got 11 things I want to do today. In the simplest form, I really want to talk about some differentiations between anxiety, depression, and suicidality. I want to talk about the 3 I's of what I say are depression. 3 lessons and caveats from community health services, and I believe that prostate cancer support groups are community health services. And I just want to talk briefly to 2 men's e-health resources. So, I keep harping back to this, but I think COVID's been a really long game for many of us. So I want to acknowledge that, the world really has changed, and I think it's directly relevant to the discussion today. We've seen the restaurants close, and certainly in Vancouver, we've lost about 25% of our restaurants. We've got 15% rise in vacant offices in the downtown precinct. We've endured, physical separations, which frankly have taken us away from a lot of things, and we've had control of, or felt like we've had control of, and also the freedoms that go with that. And so I talk about anxiety a lot. One of my favourite kind of ways of differentiating it comes from having a beer with Richard Wassersug, and him saying, anxiety is about the future, and Rich is exactly right. It's about worrying about what's next, what will happen. And I think COVID is a real trigger for that, worrying about, when does this end? Where does it go? What's it going to be like after all of this? The other one's depression. And again, that's, in chatting with Richard, is very much about thinking back. It's about that regret, the rumination on what could have been better, what should have been, what I wish I'd done better, those sorts of things. And I think what's happened with COVID is it's created a lot of space for us to think in those ways retrospectively, because there's not enough live things happening to stimulate us. So oftentimes we get pushed back into thinking about the past. I think the other thing that's probably happened for a lot of folks has been a lot of pressure on the domestic sphere, because being locked down, so to speak, has kind of pushed a lot of guys and partners back into the domestic space and put a lot of pressure on the home. And I speak to people who are working from home and often in a shared space, and there's a number of challenges that go with that. So there's a bunch of things at the moment, in the COVID context that make the content I'm going to talk about perhaps even more relevant than in regular times. If 2020 was the year of COVID-19, I reckon 2021 must be the year of the vaccine. And I really hope that 2022 is the year of reopening. But of course, there's always going to be depression and anxiety around, that time in between, and that waiting and that uncertainty for what goes forward. We did some surveys with some Canadian fellas. There's more than 400 of them, and they were between the ages of 18 and 80. And 79% of them indicated that their mental health had been negatively impacted by COVID-19. 51% of them talked about financial stress, and 37% of them said that the COVID situation had really negatively impacted their relationship. It was so interesting that 42% of them said that they had thought about suicide. Admittedly, these are men who are looking for help on a website called Heads Up Guys, which I'll talk about a bit later. But nonetheless, I think that that those numbers are pretty high and pretty staggering in terms of people thinking differently and being challenged. Just swinging back to the relationship part, we've done some work recently about men's relationships, and prostate cancer to me is one of those areas that that really is, we talk about it as a couples disease. I think, relationships really do bear out in certain ways and exhibit certain challenges, as a result of prostate cancer and the things that go in and around prostate cancer. So we've done some work looking at men's relationships, and one of the things that popped up was that, divorced men are 8 times more likely to suicide than divorced women. I just want to say that relationship in crisis is a real trigger point for anxiety, depression, suicidality for a lot of men. And just to, again, the pressures of COVID, but also the changes that occur within relationships around prostate cancer and how they're negotiated become really primary concerns. The other thing, guys in their 5th, 6th, 7th, 8th and 9th decade oftentimes carry what we would say would be comorbidities or other things, or accumulated traumas over a lifetime. The longer you live, the more things you're exposed to, the more things you're kind of dealing with, and not all of them get resolved. So in many ways, as we grow older, we accumulate these experiences. So again, in the context of prostate cancer, that we're older and have prostate cancer is often predisposing us to some of the things around, depressive symptoms, anxiety, and suicidality. I don't want to doom and gloom you. I really don't. So I want to talk about this in a nuanced kind of way. But just to say that compared to the general population, men with prostate cancer do exhibit, complications related to generalized anxiety disorder, which is GAD, depressive symptoms, and suicidal ideation, and suicidal mortality. And in COVID, I think we've had some challenges around wondering if we're more vulnerable to COVID, wondering if we're eligible for vaccines and safely able to take them, wondering if we might be immunocompromised with some of our treatments. So there's been some layering on top. Anxiety, as I mentioned, it's about things in the future. Guys often talk to me about the need to be wired, the need to be up and sort of and on, have a bit of edge about you in order to perform. And I totally buy into some of that. But the differentiation with anxiety is that it shuts down those very performativities that we want. It actually stops us in our tracks about making decisions and working forward. So anxiety is where it's just not working for you. It's not about being up or kind of even anxious. It's about a state in which you really can't move forward with decisions, and you just sort of beckoned about the worry of what might come. And oftentimes what we find are those things that are so far out of our control, but that actually spirals some of the feelings that we have. In the context of prostate cancer, we see, different times when guys are particularly vulnerable to anxiety. Certainly relates to the idea of being on treatment. Pre-treatment is often very high because you're making treatment decisions and you're not sure what's coming next. When you're on treatment, there's a little bit of a feeling of, I'm getting the help I need. And then post-treatment, there's oftentimes anxiety about, well, what's next? What if it comes back? So it does bear out slightly differently, in guys with prostate cancer. It spreads across the trajectory. And there's also some essence around what treatment you're getting. So there's a heightened anxiety. Oftentimes in some of the literature suggests that ADT is one of those ones that can heighten our anxiety in the context of prostate cancer. It's the same kind of thing with depression. It runs higher in guys with prostate cancer than it does in the general population. And so 1 in 6 men are likely to, encounter a depression when they have prostate cancer, and also, upwards of 14% as prescribed antidepressant medications. Really keen to do an audit of some of the medical charts to see exactly what that number is. I think that's a conservative number. Oftentimes the jump is straight into antidepressants. We can talk a little bit about that too as we progress through this. I think one of the things that is really interesting to me, and I think, as people working in prostate cancer support groups and people who go to the support groups, it's really important to understand that asking for help around mental mental illness or mental health challenges is not a one-time deal. It's a project that takes quite some time, and oftentimes it will take multiple asks. If you look at the fact that 60% of the guys who suicide in Canada have actually been in medical help in the last 12 months prior to their death, there's a lot of complexities. So you can be in help, but you might not be quite getting the help you want. So oftentimes about building a team, we often say, of folks to be able to help. And oftentimes what guys want to do is bridge towards self-management, which is good. But the need for professional help, is often there in the longer term. And that bridge sometimes looks different depending on what you need professionally. One little study there that I just note from Jennifer White, it's a great little study. There's 107 guys, they're all in the waiting room about to see their doctor. In the waiting room, she gives them some surveys to fill out. It shows that about 7 of these guys have what we'd say is suicidal ideation or some suicidal thoughts. They go in, see the doctor, the 107, we check their charts after they've talked to the doctor. Not one of those 7 guys said anything about their suicidal ideation to the doctor. So oftentimes, it's just a great example of you being in help, but not always getting the help that you need, or being able to articulate what it is that you need. I think, too, if you look at the suicide rates, it directly affects men more often than women. We run at about 3 times the rate of women. It's our 9th biggest killer. And so the whole idea of helping to try and curb around anxiety and depression is to get upstream of that as a suicide prevention method. And it's not to say the only route to suicide is anxiety and depression, but we know that severe anxiety and depression are key contributors to self-harm and guys taking their own lives. We talk about a discordant relationship as well. So here's the thing, guys don't get diagnosed that often with anxiety and depression. They get diagnosed about half the rate of women with anxiety and depression, but they suicide at 3 times the rate. So I talk about the black box, the pathway, the flight recorder, the pathway between anxiety, depression, and suicide as being the part, if we could map that, if we could find out what happens there, then we could start to make inroads to reducing those pathways, cutting those pathways off so as they don't progress, and helping guys upstream to address anxiety and depression, which are pretty common, but rarely formally diagnosed. So our question was, within that discordant relationship, are we missing male anxiety and depression, as a key concern for us? And so we gave guys cameras, we asked them to take photographs of their experiences. And these were guys, many of them who'd attempted suicide, many of them who had suicidality around thoughts and plans as well. And, they came back to us with photographs and we started to work through them. And there's 3 things that we found that are deeply associated with depression, and it's injury, interiority, and isolation. And so the first one being injury, and I think guys a lot of times don't talk about their injuries. And by injury, I mean things like the little things that happen along the way in our lives, those kind of injuries. And this is a really nice quote from a 21-year-old fellow where he talks about this idea that he feels abandoned, just like the building that's abandoned. And it sort of relates to the idea of growing up, having his parents divorce, neither one of them expressing an interest in having him live with them. He then has a partner, breaks up with her, and sort of is just getting these accumulation of losses. So we talk about injury in this way, and I think it's a nice picture for trying to understand that those are things that we might think we might be able to get past or should get past, but for him it's starting to accumulate. And he's only a young bloke, and it's starting to wear on him. The typical thing we do when we get injuries is we drive interiorly, and it's a kind of a guy thing because we'll look for the remedy from within, and so we'll drive looking inward, and we'll go often at a time when we're deeply fatigued by the injury. We'll be looking to be able to address the injury. And one of the unfortunate things that happens with that is a lot of times we'll get into substance use or we'll start to overuse alcohol as a way of kind of blunting or getting some freedoms from the injuries. And we see it all the time. So this from a young bloke, he's a 31-year-old South Asian fella. And he really talks about this notion of unlocking. If you know the combination, you can unlock. So you can see he's not looking externally, he's looking internally for the answers, and he's trying to drive a solution. Again, you know, Raj talked a lot about alcohol use as a way when he couldn't defeat what was going on for him or couldn't remedy it, that he looked for things outside. You know, it's funny when as we're growing up, we're often told to kind of control our emotions, and boys are told routinely, you know, to suck it up and don't cry. The trouble with it is we get that far away from our emotions, they're lost, and then they might explode in anger at best, or might just be so far deep down that they're never really addressed. So the recognition and management of something you're denying is near impossible. So if it gets submerged deep enough, it's really, really tough to try and deal with some of this stuff. The final one is isolation, because if you've got an injury, you're driving inward and you're not really able to cope with it or deal with it, then you tend to isolate. And a lot of guys do this to kind of conceal the fact that they're dealing with things, and that they're, you know, trying to work their way through it, but aren't really having that much success. So they kind of isolate. And we have this idea of isolation, social isolation, of guys being, in particular, kind of the lonely guy in the corner. A lot of times we see men who are, for all intent and purposes, connected. They've got people around them, they've got families, they've got work, they've got mates, they hang out, they have a good time, and they're profoundly disconnected. And again, you know, this is from a young man, 28-year-old, who's driving home from work. And the quote is very, very clear that he's feeling alone. Even though he's just come from work, he's on his way home. And at work, he's working with, you know, upward of 50 other employees, like, you know, life of the party guy. And so, but that aloneness is still there for him in heading home. There's lots of theories about, you know, men's suicide. I think one of the things that is worthwhile thinking about in terms of prostate cancer support groups is that you do a wonderful job of helping people belong, and a great job of helping people reduce the idea of being a burden. So guys, a lot of times will feel they don't want to burden their mates with, you know, their woes about, oh, I'm pretty challenged by A, B, and C related to prostate cancer at the moment. Don't want to sort of talk that down, don't want to sort of get into that narrative. Groups provide a safe space for that, so it reduces the burdensomeness. And that sort of belongingness, you know, sometimes when guys have a loss and they feel a bit like they're not kind of one of the crew, it can kind of, you know, edge away at their belongingness. And so groups do a really nice job, even if it's just once a month, bringing people together who have shared challenges and are working through them. And I think that belongingness is really, really helpful. Joyner says that when you've got perceived burdensomeness, low belongingness, and the capability for suicide, that's when it's most likely to happen. And so you might even think about prostate cancer support groups in some way, shape, or form as doing some really amazing work around suicide prevention. Oftentimes we don't think about it, but I would argue that when I go to the groups, there's a camaraderie there that's deeply important for not having people isolate their injuries and drive entirely inward looking for the injuries. When we look for depression in a clinical sense, we often use what's called a PHQ-9. And the trouble with this is that it may miss some of the symptoms that we see in men with depression. So what we do see time and again is anger, irritability, substance overuse, risk-taking. And there's nowhere on this form when we screen in a clinical sense do we have those symptoms. So it's super interesting to me that we really do need to think about those, about, you know, this emotional suppression, drug use, alcohol use, anger, and aggression, somatic symptoms, risk-taking. So I guess the message here is that when you're, at a group and there might be someone who's not really participating or coming off as a bit edgy, a bit angry, it may well be that it's an early sign of depressive symptoms. So there may be some things going on that are manifesting in that way, because we're convinced that early on what we see in men who have depressive symptoms are these things: anxiety, irritability, anger. We're doing some work and it involves what's called a men's male depression risk scale, and it does include these items around anger, irritability, substance use. And we've run it in samples of prostate cancer guys. And so our findings suggest that, one, and this is not surprising, but it shows up that guys with prostate cancer are more at risk for depression if they have a comorbidity. I mean, it makes sense. So if you're running diabetes, heart disease, some other issue that's running next to the prostate cancer, there's a heightened likelihood of depression. The other one that we found, and it's kind of interesting, this one, anger is interesting because at some levels we kind of say, oh, well, that's how guys express themselves. But at another level, there's a deep amount of shame that goes with losing your cool and being angry. And so anger turned inward precipitates depression. And so this emotional suppression potentiates anger as well, and then drives depression. You get my drift? Because what we're doing is we're like cascading here. So, not to simplify it too much, but to say that the emotion suppression doesn't help a lot of guys, right? So driving it inwards tends to drive the depressive symptoms manifesting as more anger. So just to say, again, this is borne out with prostate cancer guys. So it's kind of interesting that we're heading in that direction. I got a question before the seminar, which I actually really appreciate. And so I'm going to turn it right back to you and just say, this is the question, and I'd love to hear and see the text for this, and help me out here, Rochelle. The question was, what causes men to stop talking and bottle up their feelings, and how can we encourage talking? There's a lot of experience in the Zoom room today. Super interested to hear your thoughts. And I'm sure that Rochelle can help us facilitate this.
Absolutely. Does anybody have anything they want to share? Go for it, Len.
One of the things I think is helpful is that when the people come to a support group, they're among people with the same kinds of issues. And so they feel more comfortable sharing their concerns. And I found that it opens up a lot of people for things that we would never have thought about before. We did have, actually, if I can share this one experience, we had a young fellow who was in his 50s, early 50s, who had been diagnosed with prostate cancer. And he came to our group because I had done a presentation at his company. He came to our group and he shared his experience and his depression and anxiety with us. And it was marvelous to see all the fellows in the group come together to support this fellow. It was just marvelous to see that experience. They all helped out. It was marvelous. Thank you.
Great example, Len. And it's such a powerful example too, because if you norm a problem, then a lot of times what you do, you position it as a challenge, and then you norm the idea that we need a remedy, we need to work towards addressing it. So such a great example of affirming the existence of a problem, normatizing it in terms of a lot of blokes in the room would have experienced some elements of what he was talking about, and just hearing him, massively important.
Lori and Boyd?
Turn yourself on.
Yes, I'm turned on. Thank you. Actually, having some experience with mental health myself, one of the things that I experienced as a practitioner was a lot of myths, misperceptions, and stigma in regards to mental health, and especially with men. You had mentioned in your talk that men very much, have that old belief system of suck it up and yeah, just suck it up.
Yeah, it's interesting, isn't it? And it's there'd be a few different explanations for it, in relation to this question. But one of the explanations is that the guys are kind of taught to do that. And it's kind of that's what's kind of valued, is to be quiet on it. And the flip of it is that if you're not quite running, 100% rational and kind of all good, mentally healthy, it can be seen as weakness. And so we often don't talk about weakness, and because it's kind of incompatible a lot of times with being a guy who's meant to be operating differently. So it's kind of interesting where it comes from as well. But thank you for that. I really appreciate that input.
Yeah, thank you.
Roy?
Yeah, my comment towards your question there, John, is when you think about men, and especially men when they get to the stage of dealing with a crisis like prostate cancer and whatnot, it's generally your later part of your life. And I know for myself that when I look back on my work life, I didn't really have that many guy friends. I had associates at work. I had associates outside of work, but I didn't have that many guy friends. Somebody that I could go and share a beer with and pour my heart out and know that what was said there stayed there. I think that's the biggest problem. And when you move into another strata or you're faced with a crisis like cancer and whatnot, you're probably transitioning into retirement or whatever, and you lose what little bit of social structure you have. And so then it's kind of like the goldfish that got thrown in the pool and he doesn't know where to go. So that's kind of my take on it. It's not an easy thing. I think one of the things that you have talked about this in the past, and I'm actually involved in the Vernon group here, not on a hands-on basis, but as a member, and that is Men's Shed. Men's Shed is a great avenue to reestablish that social network that's so critical. And the social network doesn't always mean just your spouse. It has to be outside of the marriage. And marriage can be strong, but I think the part that's outside is what will help keep men from going down the wrong rabbit hole.
Great insights, Roy. Thanks for your candor there. I think, terrific points. I love that point about transition, so we oftentimes, it's weird, we often talk about transition as being one thing, but like you say, the transition to having prostate cancer might coincide with the transition from work to retirement, might coincide with a bunch of other transitions, and we just might not, we might have, even if we had a team built around us that were good supports and good mates, they might be gone by the other transitions that are happening. So it's such a poignant point that you make. And I've got a slide about the Men's Shed, so you segued very nicely for me as well, Roy. Thank you for that. So we'll talk a little bit more to that. So thank you.
Sue and Patrick. You guys are muted.
I thought you were unmuting me. Sorry about that. Yeah, in my own experience, and I facilitate a women's support group, like spouses of men with prostate cancer. And my personal experience has been that I think if you're used to men are used to bottling up their emotions and feelings, and they risk it, and they let themselves be vulnerable. If the first time or the first couple of times that happens, it isn't a good experience, I think that really causes them, like, what I see is, I mean, prostate cancer is very difficult for both the person dealing with it and their spouse. And I think sometimes when men start talking, it doesn't come out like women talk about feelings. And so it comes out talking about situations or questions. And if it gets dealt with on that level, I just think the people around men with prostate cancer, if they open that door a little bit, you have to be really calm and listen. And that's the most important thing. Just let them talk and listen, because it's so easy if people take that risk and it doesn't go well. It takes a lot of courage that first time. So anyway, that's what I've seen. And I'm really bad at that, because when my husband was willing to talk, I mean, I'm going through my own stressors too, so I'm not at my best either listening. So that's another reason, guys, I'm just saying this as a spouse, that's another reason it's so important for men to talk to other men who aren't in the middle of this with you.
Yeah. So yeah, you make such a great point. So it's that delicate balance for partners to work with the guy, but not to take on, the full weight of the burden, because you can't. Ultimately, like this comes down to self-management and professional management, if that's the severity of it in the end. So it is a challenge, because sometimes our partners might be the primary health provider in the family, like it might have been always the way. But these are complicated matters that can be long term and can really be a huge burden. And it's not to say not to have the conversation. Then conversations are important, but as partners, not to take on the remedy of it. Because to listen is one thing and to help guide is one thing, but ultimately this comes down to self-management plus or minus professional help, to work through. These things are complex. So I genuinely appreciate your points. So I hope I added to your perspective a little bit there.
Thanks, Sue. We've got two more hands here. Sue Hammond.
I help run the Newfoundland and Labrador prostate cancer support groups. And we ran a campaign about 2 years ago called Time to Talk, very issue. And we did a photo of a husband and wife. We did a photo of a father and a son. But the most profound one for me was, and the shortest time it took to do the photo shoot, because we were using local people from the province, was a man who was in his 50s, and he was talking to an older man into his 60s. And he had been so caught up with being diagnosed, having treatment, finding he needed further treatment, that they just started chatting. And the older man had been through some of it like he had. And they started talking. In 15 minutes, we had the photo shoot done because it was so genuine. But it was the time of his disease journey that he started talking about it. Suddenly, he said about a month before that he had just been able to sit down and just realize what was happening to him. And the fact that this man was there, I got them to come upstairs and continue. They continued on for another hour or more, just between the two of them. And suddenly it had all hit him And he was open to such a profound pouring out my heart and discussing this whole thing. And it was the support group man that was there that was able to really, really help him open up.
Great story, Sue. Great, like, and such testimony to, you know, the value of the groups. You know, I often think about the thing I've missed most with COVID. It's social connection as well, right? Like, it's, you know, it's that very essence of being there for someone and being able to talk through things. So I love your example. Thanks for sharing it.
Thanks, Sue. And last hand is Keith, Toronto.
Hi, I just want to make a comment about getting men to talk in the context of a support group meeting. And I only have the experience of my own group. And I find men come to the meeting, and we don't know how to lead them on to talk, because men in a support group tend to focus more on numbers. And they'll ask, what's your PSA, what's your Gleason score, what's this, how many cores, how many percentage in each core. And if the man came there more for emotional help and doesn't remember his numbers, initially at that initial interaction, you tend to put them on their back foot, and they tend to withdraw then, and then they don't talk about their emotions because they're feeling embarrassed that they didn't know their numbers. Whereas if we tell them, you know, and I you know, I can understand none of us in support groups are trained in counseling or in psychology, or, you know, if we can just tell them, you know, tell us how you feel, and if you remember the numbers, fine. You know, the numbers are not relevant to us. They're more important to your clinician than to people in the support group. And, you know, then I think we can get them to talking and, you know, maybe asking more open-ended questions, not related to anything clinical, and more in terms of saying, you know, how did you feel? Did you feel angry that this happened to you? Are you afraid? You know, we've all been through the same thing, and each one has gone through it at varying degrees.
Right. Yeah. What a great insight. And it's true, you know, sometimes the things that make us rich make us poor, right? You know, so I've always been a big fan of the groups because they teach literacy, and they talk about PSAs, and you know your PSAs and Gleasons, you learn about all of that terminology. But yeah, it's that blend of trying to create the safe space for some of the other things. You know, it's interesting in our observations of the groups, you know, we've done studies and things. We find that some of these conversations happen in the breaks. You know, when someone's having a coffee, and it might be one-on-one, and they talk about their distress, or stress is a real calling card. A lot of guys will talk about stress, and you'll hear it in the conversations, oftentimes one-on-one. And, you know, and sometimes the opportunities emerge there, but I agree with you. You know, we've got an obligation that if we're at a group and we kind of have a moment where we hear something that's cueing towards how someone's feeling, I agree. You know, we've got to try and pick up on some of that in a way that enables the conversation to keep moving, you know, to embrace some ideas about that. You know, it might be as simple as, I felt that too. When I was diagnosed, I felt exactly the same way. Like, and here's some things I thought about to try and get through it, you know. Just an opportunity. So just picking up on those nuances, but it's a really keen observation that you make and share. So thank you for that.
Dr. Oliffe, there's two more hands. Are we okay to do that?
Sure.
Okay, thanks. Frank, did you still have a question or a comment?
Yes, can you hear me?
Yep.
I was just going to add, I think some of these points were raised. I look after the Calgary Warriors in terms of moderating the group there. And I think there's a number of factors that influence the willingness of, you know, prostate cancer patients to speak. Among them, what I think is, you know, there's those that have fear and denial, and they just don't want to address it, period. There's others that feel like who can really help me? And will people understand? And how will they react to me if they know that I have cancer? And I don't want undue attention. I don't want people to continuously ask me how I'm doing. These are things that happen in terms of those social interactions. And I know, for example, even with a fellow recently that approached our organization, they were in a fairly senior role and they were worried about advancement, promotion, and the impact. So therefore, they wanted to keep this whole thing very secret. And there's also the stigma that's still associated with prostate cancer, and that is, the sexual dysfunction that typically occurs with most people. And so there's a reluctance to really, to talk about that. I think that what I've seen in terms of at least certainly those that I've dealt with is that the doctors don't really talk about the emotional side. They talk about the medical side, and they really don't give you very good resources to access. I mean, that isn't part of the discussion with the urologists, the oncologists, or anything else. They're there for the medical side. And there's probably more that could be done in terms of that information. And I think that the support groups are critically important because they are then talking to individuals that have had a similar life experience with cancer, dealing with it, and they can relate and engage and feel safe. And also, I think that up until at least your discussion here, there isn't really a lot of literature about this and prostate cancer patients and how they feel in terms of depression, suicide, etc. It's a relatively new area, and I don't think very understood at all.
Yeah, I absolutely agree with all your observations. They're very keen observations too, and medical system is specialized, and one of the most fragmented pathways in the medical system is to find your way to mental health care as specialist care. So again, that it can be a blind spot in our treating oncologists. Also is a barrier to finding some of those pathways. So again, the groups can do a great job with that. I think too, one of the things I've noticed with the groups over the years is sometimes, in relation to prostate cancer, there might be a certain bent towards a particular clinician who's really good, like someone who's really good. You should see such and such, they were really good. And if there was that kind of resource around mental health for guys who might have gone that route, even just momentarily for some talk therapy or whatever, what gems to share with other people in the group who might, think, well, yeah, if he found him all right, then why don't I give it a try? So again, those informal ways, but I agree. We need some system changes for sure to help make the pathways a bit easier to access the help. Thanks for your observation. A really keen observation.
And last but not least, we have Joseph. Just click the unmute button on the bottom left there. There you go.
Hello. Hello.
We can hear you now.
You can hear me okay?
Yeah.
Yes.
Thank you.
I'm from the province of Ontario. Been a survivor of prostate cancer since 2014 and been a volunteer with the prostate cancer group in Burlington, Ontario. My first question was, when I saw this question go up, I started off with a question, but as I heard other members speaking, and particularly, I believe it was Frank Alkin who just finished making some very good observations and shared with us. So the first part was, what causes men to stop talking and bottle up? We know that. In the support groups, we know that. We've talked about it. It's been echoed this afternoon many a times. My first question is to Dr. John Oliffe. What studies have been done on this, if any, and if not, why not?
So there is a bunch of work that's been done, and it is interesting. It doesn't, it doesn't always connect to mental health, although increasingly it is, and it doesn't always connect to prostate cancer. But there's a lot of literature out there that talks about the idea that masculinity would suggest that you need to be competitive, self-reliant, and stoic. They're the things that are prized most about being a man. Whether that's wrong or right, it's often the normative frame that we govern our expectations. So guys align to that differently. And so some of the causes are, if you buy into that whole discourse around, well, blokes don't go to the doctor, blokes don't talk about their problems, and you steadfastly stick with that, and that can be one of the reasons that you're not talking about it, that you're bottling things up because there's an expectation. Some of my psychiatry friends would say that it's about alexithymia, so more of a kind of a biological construct / socialized construct, where guys don't know what's going on around their emotions, hence that difficulty in articulating what those emotions are, because they're not quite in touch with them. I'm sure Richard's got a biological one for us as well, but these are the kind of things that there is there's literatures out there that sort of say, hey, this is what we think it is, this is where it comes from. And in the relation to the masculinity piece and about encouraging guys to talk up, we'll often talk about that it's actually a strength-based activity to talk about what's going on for you. Like, it's strength. That's courageous, because if you think you've got a problem and you're invested in talking about it with a view to trying to fix the problem, surely that's got to be kind of courageous and strength-based. So we try to flip that idea about what it is to be a guy, in terms of normalizing the idea that we all need help at some point, and sometimes we've got to build a bit of a team to move that forward. So yeah, long answer to your question, but there's not an enormous amount that's in the context of prostate cancer support groups, anxiety, depression, suicidality, that's actually melded together what goes on, or what shuts it down, or what doesn't shut it down.
John, you have a very simple way of describing things. On this particular one, I got a feeling that it was more of a political answer as compared to really head on. And I mean that very, very politely. Being a survivor, I think I could share these feelings. There's no better way to put this question under a microscope and get some research going. Regardless of whatever is happening in other fields or wherever, we heard it from, Sue Hammond and the group that she's had, and the patients, and the 50-year-old talking to the 60-year-old, and Frank Hankin and myself, and I'm sure many others. We have such a simple question here right before us, and yet we're avoiding to take it head on through a study. At this point, I would suggest that we table that somehow or another we get to the core and root of this and really address it through studies. Not to come up that we don't have any funds, not to come up because men are different, not because there's really an undercurrent that's very powerful here. And English is a very specific language and very articulate. And what it says before me in this question is, if we could have studies, and I come from a pharmaceutical company, so I know what studies do to patients and doctors and the rest of it. Then we have a support that we can put in literature. As Franklin mentioned earlier, there's really not much in literature. Prostate Cancer Canada had a lot of literature, but this issue about talking is a critical one, because that opens up the whole gamut of the support group, of addressing the problem head on. So I can't make it even more importance on this, and perhaps table it, it's maybe report someday down the road as to, are you going to take any studies with regards to this particular question? Yes or no? And if so, what's the timeline? Because we're way overdue. on this, addressing this question through medical research. And then the support groups can take that second step. Once it's announced in some literature, take those report findings, and we could expand on them. Not that we don't, but we'll have something more to open up. There's a lot of things thrown at the support groups, so we need a little bit more structure. And I think that part of the structure for support groups will be facilitated by these studies.
Yeah.
I speak from my own experience and how I was able to.
Yeah, no, I appreciate that. I appreciate that call to action too. You know, and value your perspective. Yeah. You know, we've got one in review at the moment. Probably shouldn't tell you, but we've got one in review. We'll know in June. And in part, it does address the very questions that you're talking about from an empirical basis. We've got a 15% chance of getting funded. And look, if we do, then we'll be on our way. We also have some data from previous times of being to the groups that we could probably go back to and ask this explicit question of to try and get a bit more of an empirical foothold on this as well. So I appreciate your candor, and I appreciate your drive for the empirical base here to help us push you along.
Thank you.
Rochelle, should I push on a little bit here, or yeah?
Yes.
All right. I just want to say, shout out. I genuinely appreciate the perspectives and the things that you've shared. Deeply grateful. I'll skim through the last couple of slides because I appreciate you've got some other things for your back hour, but genuinely appreciate the conversation. You know, the Lone Ranger thing is something that we've observed for a long time. The trouble with the Lone Ranger thing of do it yourself or not get it done properly or effectively yourself is that it gets worse with time. It's like, you know, I don't like this analogy, but people say it all the time, you know, trying to walk on a broken leg. Something's not right and something's not fixed. It gets to a point where it's just not going to get better by itself. And so we see guys often late, and, you know, it's increased cost to the guys, their families, and everyone around them in terms of if they're holding a job and what that means. So it's about trying to sort of, you know, break the deal of that one. As I mentioned, we talk a lot about what men do well. And so we'll talk to them about being a good protector, if it's something they value, provider, courage, logical, responsible, loyal. These are all strength-based values that many, many men hold. And so if we can talk to them about addressing a challenge around their mental health, then the idea being that these roles that they've got and these values that they have, they can be in the best shape in which to continue those roles. So more of a strength-based rather than, you know, what you don't do, which we know doesn't really drive affirmative action in a lot of guys. So really being positive. We've talked a little bit about this, and it's great, you know, in the conversation, you've kind of come up with these yourself. If a guy puts out a calling card, and the one we're cued for all the time is the word stress. I'm a bit stressed. And oftentimes we'll hear that and we'll be like, so no one says depression. You know, anxiety maybe, but no one says depression. Guys don't say depression. They tend to talk about, yeah, a bit stressed out, you know, it's been really rough, blah, blah, blah. Affirm them in what they're saying, you know, and sometimes you can say, oh, yeah, likewise, I'm feeling some things, you know, sort of normalize it. The permission to talk, never shut them down. So that the idea that you validate them, that it's a real experience and you're listening to them is absolutely key. You can shut a guy down very easily by topic changing the minute it's uncomfortable for you because you've put the burden of remedy on you. So you just have to listen. You have to stay with it. We always trade on courage, but it's strength-based. A lot of people worry about, look, if I buy into this conversation, the trigger me. If I say something, if I say the wrong thing, then I could end up really regretful because he's self-harm. Opposite is true. Most people, if they're experiencing anything around suicidal thoughts or self-harm thoughts, they're usually really, really scared by those thoughts. So if they have been courageous enough to sort of put some of it out there, You really got to run with it. You've got to listen to it. And it's not like asking questions like, so how is that occurring? When does that happen? Is going to trigger it. It's like it's more than likely going to help them unpack some things that they've been holding deep inside and causing them substantial distress and stress. Follow-up's important because if you self-disclose as a guy, usually there's a bit of regret. Usually there's a bit of, oh, gee, I don't know if I should have, because you're kind of not used to doing it. And so a lot of times in therapy, you get used to doing it, but, you know, regular times, probably not. So it's keen to follow up, to just check in. How's it going? Thought I'd catch up, you know, and revisit just in a way that makes them know they were heard, but also not be embarrassed about what they said and you disappear off into the sunset and never get seen again. We talked about professionalism, professional help. It takes resilience. This is not a one-time ask. You can ask for help professionally, and it might not be the help you need. It might not fit. You're going to have to build a team, and that whole team basis is incredibly important for driving this stuff forward. And community that I'll talk to in a moment, and e-health is massive. Switching some things off. So this is less about giving advice and more about some self-talk. We all, you know, are challenged by different things around anxiety, depressive symptoms. Switching some things off can be as simple as a little bit of concentration around mindfulness. And I know that the word's not that cool, but the idea of even just focusing on your own breathing, put it that way, to just not stop the thoughts, but just to take your focus somewhere else, just to waylay some of the anxiety, some of the depression, just try to take a little time in terms of switching some stuff off. Never more important than this COVID stuff. You know, it is incredibly powerful to switch some stuff off. So there's lots of apps, there's lots of free stuff that you can use that can help you, but you can actually do it as simple as breathing in deeply through the nose and out through the mouth, you know, on a 4-4-4 progression, like in for 4, hold for 4, out for 4. Do that for a couple of minutes. It'll really help to just focus on the breath and just to switch some stuff off. I want to close with a couple of things. I will be done for the hour spot, Rochelle. Sorry to run a little bit over here. 3 caveats from the community health piece. Roy mentioned about men's sheds, really, really important. They connect by doing. One of the criticisms of prostate cancer support groups is that they're not active enough, that they're more talk-based when we've been in person. I think we can learn a little bit from the sheds in terms of they're usually doing something like some shared activity, and they often talk about this shoulder-to-shoulder situation where they talk shoulder-to-shoulder, not directly because they're doing something and the talk just emerges in and around what they're doing. Great for guys who are transitioning to retirement, going through things like transitions like bereavement, divorce, because this is volunteer-based. You show up, you might not show up next week, you show up when you want, you know, and it's an activity where there's other blokes there and you can continue on with whatever project that they're doing. Been really good. The thing that we caution the men's sheds guys about is that the men also connect by talking and through silences. So we talk to them about pacing. We say, don't make it too busy that the guys are just like so busy that there's no room to talk. So that's one of the things we do. So it's this delicate balance about activity versus the room to talk. Your breaks at prostate cancer support groups are incredibly important. You know, if I was putting a break in there, I'd always go to 15, 20, 30-minute break because so much happens in those breaks that you might not get in the big group. The other thing I'd say about, and this directly relates to groups, I believe that groups have always shifted what it is about how men do health. I think you're actually the opposite of what we say men do, because what you do is you create a flat field where people can talk. Guys can admit, you know, things that are challenging them and be affirmed and be able to talk about those things in ways that aren't available to many of us in other walks of our life. So when people say to me, and especially prostate cancer support group leaders, they say to me and say, John, I'm really worried because we're just not getting these swollen numbers. We're not getting huge, big numbers. You know, we've got guys who show up, they'll show up once or twice and we'll never see them again. My answer to that is that there's some guys who just aren't built to stay in a group, but never underestimate the value of what you gave them by them showing up, taking what they needed and moving on. Not everyone's going to be a stayer. I know that doesn't help in terms of leadership succession, which is a key issue. But at the same time, if you could build something that was going to fix a person or help someone, you know, with one-time visit, gee, you've got to be pretty happy with that. And I'm not Pollyannaing it, just saying that I believe a lot of times that guys, they'll come to the group, they'll get what they need, they go, or they come to the group and go, I don't know if I can stay in this space and keep continuing to talk about these things in the long term. It's okay. Don't shift what you're doing. Let those people come and go because you're still providing service to them. Just a paper that we wrote about this back in 2008. The last thing is just to say, you know, in terms of literacy, what I mean by literacy is all the things you talk about with PSA, Gleason, all of those things. If you don't have that language, then there's a stigma because you can't speak language. It's like going to Europe and you really can't speak French and you're in France and you're not quite getting the experience because you just don't get the language. And what it does is it mutes people. So while you do a really good job of it, I think it's definitely important to know people's language and their beginning language for where they're at as well. So we often say work to know the men's language and work with it. Classic example of this, we did work with veterans here at UBC, and they're brought into a group which would be maybe formally known as counselling psychology, but it's just a group. And the way they recruit men into the group is they say, well, you know, you haven't got a problem, but a few guys at the group could do with your help. And these military men, they show up in the pretense of helping others. And of course, there's a reciprocity in that help and it's professionally facilitated. But again, it's about knowing their language. Their language is around camaraderie and having the guys back. And they talk about dropping their baggage and they talk about release. So there's a few tears shed at these intensive workshops, but it's not called crying, it's called release. It's the release. And so again, just trying to work with those kind of that language. A shout out for If I Were Tom, you probably know it. It is trying to simulate some of the great things that prostate cancer support groups do. So it can be a helpful one for people who can't make it to a group, don't want to go to a group. You know, it can help to answer a few questions. There's experts on there. There's guys with keen experience, partners' experiences as well. And the other one is, this one's been really good. Heads Up Guys, and it attracts 60,000 unique visitors every month. And it really focuses on depression and some tools for self-managing. So it does a really nice job. So again, this is a really strong website. Yeah, I want to close by thanking you guys for your work. You know, this is, whether you're in a leadership position or not, you know, I often say we lead from anywhere, so you don't have to be in a formal leadership position with the support groups, but, you know, this idea of looking after yourself first gets bathed these days as, you know, maybe a bit selfish and whatever. Nothing could be further from the truth in my experience. If you're not looking after yourself, it's pretty tough go to be able to be there for other folks. So it really is about a self-management project, as well as doing good for everybody else. If you like some of what you heard, you know, and we speak out on Twitter, we got lots of feeds and things like that, and we're always doing projects, always keen to hear from you, and always been a big part of the prostate cancer movement here in Canada. So looking forward to continuing that. And thanks for today. It's been really, really nice.